Hello, welcome back to Drugs and the Brain, welcome back to Coursera, welcome back to Caltech, and in fact here is my Caltech Pocket Protector that proves that we are at Caltech. For those of you who still use pens and pencils these days, it will sit in my pocket for most of the lectures. During this mini lecture we are going to continue the organization and overview of the course. We'll describe weeks 4 through 7. We're going to concentrate on drugs for neural diseases in the last part of the course. And we got to there because of the basic work that we did in the first 3 weeks. We talked about drugs, recreational drugs in week 3. Now we turn to drug addiction. And we usually think that drug addiction occurs because of changes that occur in the brain with chronic drugs. We'll talk about changes at the system level, at the circuit level, and finally at the cellular level. Here is an example of the idea that nicotinic receptors in nicotine addiction actually hijack an intracellular messenger pathway by allowing calcium to flow directly in through those messengers. Don't worry about the words that we will use and the molecules we will mention. We will certainly define all those words and molecules and show you how they work. During week 4, we will also discuss morphine addiction. So nicotine addiction downstream from a ligand-gated channel, morphine addiction downstream from a G-protein coupled receptor. During week 5, we'll discuss 2 important neurodegenerative diseases. We'll talk first about Alzheimer's disease, the most common neurodegenerative disease in most modern societies, and we will also talk about Parkinson's disease, the second most common. Parkinson's disease is a particular interest of my research group because it dovetails with our interest in nicotine addiction. People who smoke actually have a lower risk, not a higher risk, of developing Parkinson's disease, and so we are interested in this apparent neuroprotective mechanism by nicotine against Parkinson's disease. We'll discuss the parts of the brain that degenerate, especially the substantia nigra, and what researchers can be doing about developing better diagnostic reagents, better diagnostic procedures for Parkinson's, and of course better protective and therapeutic agents for both Alzheimer's and Parkinson's disease. During week 6, we're going to talk about 2 neurological diseases that can be mitigated by drugs, and they can be mitigated in an acute fashion, that is, hours or days of treatment with an anti-epileptic drug can begin to stop seizures. As usual, we'll teach a little bit of disease-oriented neuroscience as we go along. Here are 2 regions of the brain in which circuits are thought to malfunction during some types of epilepsy: the cerebral cortex in connection with the thalamus. We'll talk about migraine as well and the various ways that a migraine attack can occur, and the triptans, which do in some cases a pretty good job of suppressing those attacks, again if used acutely, a few minutes, a half hour before a migraine attack. And then in the rest of week 6 and all of week 7, we're going to be discussing drugs for psychiatric diseases. We'll begin in week 6 by talking about anxiety and the drugs that are effective against anxiety. The classical anxiolytic drug is diazepam, and we'll talk about its action and its advantages and limitations. Then in week 7, we will talk about depression, an enormously destructive disease. The classical, typical antidepressants like fluoxetine, and what we know about their mode of action. It's a bit discouraging that these drugs act in only some cases, not all cases, and that they take 2 to 3 weeks to achieve their full benefits. The newer and very experimental class of antidepressant compounds typified by ketamine will also enter in our discussions. Ketamine produces some antidepressant effects within just an hour or so, but you'll remember that ketamine also figured in our list of recreational drugs, and it is in fact abused by some people. So we need better drugs than ketamine, but first we need to understand how ketamine is acting as an antidepressant. Then we'll turn to schizophrenia and the antipsychotic drugs. We will be discussing the typical antipsychotic drugs such as chlorpromazine, which works on a G protein coupled receptor, and the newer so-called atypical antipsychotic drugs such as clozapine, which also works on dopamine receptors and in addition and on other receptors. We'll also be talking about drugs for bipolar disease as well during week 7. So week 7 will concentrate on psychiatric disease. Our example bipolar patient will be Van Gogh, the brilliant painter whose work evolved to be more and more daring until these very daring self-portraits just a couple of years before he killed himself. And our example of a schizophrenic will be John Nash, as portrayed by Russell Crowe in the movie A Beautiful Mind. Here, the problem, of course, is that most schizophrenics have auditory hallucinations rather than visual hallucinations. But to make a good movie, one needs to show the visual hallucinations as well. So we will then take a step back and ask what the research community can do to develop better drugs for the central nervous system. And as an example of a discouraging trend, we will talk about Eroom's law. This is a term coined by the authors of a paper in Nature Reviews of Drug Discovery. They call it this because it's the opposite of Moore's law. Moore's law says that computers get faster and cheaper every year, but Eroom's law says, unfortunately, that it becomes less efficient and more expensive to develop drugs every year. Here, for instance, is their plot of the years 1950 through just about the present, and the number of drugs that can be developed per $1 billion US of research and development spending. And in fact, in 1950, one could develop roughly 30 drugs per $1 billion spent, but there is this exponential decrease here, this straight line on the semi-log plot, until at present you can develop much less than 1 drug per $1 billion. That is, it costs more than $1 billion to bring a new drug to the clinic these days. This is especially true for drugs for the brain, and it is true because, in fact, we know a lot less about drugs for the brain than we have assumed that we know. Well, we need better ideas, and I have been suggesting some ideas that I think may be helpful for some problems. And I call the ideas about how psychiatric drugs might work inside-out neuropharmacology. And if time permits during the course, I'll tell you a little bit about the idea that although we have been discussing drugs that bind to ligand-gated channels and to transporters and to G protein coupled receptors, that remains true, but in fact drugs might actually be binding for their therapeutic effects to these same receptors, but while they're being synthesized deep within the cell. So there are some ways that we can think about to advance pharmacology, but we will need the enthusiastic participation of people like you who want to learn about drugs and the brain and who want to make your own contributions. So that is the wrap-up of our introduction to the course, and in our next lecture we'll talk about what is a drug.